it's recorded. So today we are going to cover sensory, neurological, and musculoskeletal conditions. So lots of information to cover. We're going to start. Oh, pause. I forgot to do this last class too. There is a question on your quiz about the proper position to administer medications. It was the last question on the quiz. So you will get credit for both semi-Fowlers in a crib and sitting in the nurse's lap. Either one of those are correct, depending on if you went by the book answer or the Kahoot answer. So you guys got credit for both of those, and I already adjusted grades for those. So I just adjusted them. So
Thank you.
yes, I forgot to mention that. Okay, so moving on to sensory disorders, starting with our ears. So we have differences between our immature newborn ears and our adult ears. So the big thing being that our tympanic membrane is almost horizontal, and it's going to be a lot more vascular. They have an inconsistent light reflex, and then they have shorter, straighter eustachian tubes than adults do. So that's why when you're giving ear drops to infants, you pull down and back to straighten out their ear instead of in older kids and adults where you pull up and back to straighten out their ear canal. And then the function of our eustachian tube is to provide ventilation, protection, and drainage. When we're doing our assessment, we also want to do careful observation of the alignment of the ear. So we want to make sure that the ear is in line with the outer canthus of the eye, if we would draw an imaginary line there. If we see low set ears, it can be associated with kidney disorders, also Down syndrome. When we're looking at ear infections, we have otitis externa. Also referred to as swimmer's ear. You're going to have some pain and tenderness when you're moving the ear around. This one, you'll have a normal tympanic membrane, but we need to also rule out foreign bodies, cellulitis, diabetes, and herpes as potentials. And then when we're giving our medications, we're going to use a wick or a loose gauze that we place in the outer third of the ear so that we make sure the medication goes exactly where we want to. Otitis media is going to be an infection of our middle ear. So our middle ear opens into our mastoid sinuses and is going to be connected to the throat by our eustachian tubes. They're lined with mucous membranes, which makes it really easy for infections of the throat to spread into the ear. When we're assessing for otitis media, there's a lot of signs and symptoms that we can see. Our kids like to rub or pull on their ears. You might see them rolling their head from side to side. You could see things like hearing loss or speech changes. So they'll either talk really loud because they don't realize how loud they're speaking, or they might have articulation or speech development problems. You can also see inattentive behavior just because they're not hearing you like they normally would. For otitis media, you're going to have that red bulging tympanic membrane, and your eardrum can rupture if there's an abscess that forms. We consider it to be chronic if it lasts for more than 3 months. Typically, we're going to give broad spectrum antibiotics like amoxicillin. We need to make sure that our parents are completing their full course so that we don't have a recurrence. If medications don't work, then we might have to intervene with surgery. So we can do a myringotomy, which is where we make an incision in the tympanic membrane to relieve the pressure. Or we can do a tympanic membrane button or tympanostomy ventilating tubes. So those are the ear tubes that you hear about. And those are going to provide continuous ventilation. They can fall out spontaneously around 6 to 12 months after they've been placed. And as soon as the incision site is healed and the eardrum is intact around the tube, we don't have to do any of the precautions around getting water in the ear. So they don't have to wear earplugs when they go swimming or showering. You don't have to have that constant monitoring and prevention of getting water in the ear once the eardrum is intact again. In the event that the tympanic membrane would rupture, we want to place the child on the affected side so that we can promote that drainage and relieve some of that pressure. And then we can use ice as well to relieve swelling. Our kiddos that have hearing impairment can have multiple forms. So newborns with hearing loss that they're born with are considered having congenital hearing loss. Hearing loss that occurs when the tympanic membrane blocks sound from going to the middle ear is going to be conductive hearing loss. So that prevention of sound transmission is going to be conductive. When we're communicating with a hearing impaired child, we can do things like lip reading, sign language, put things in writing, or use visual aids. And our body language is going to communicate a lot. So some things to keep in mind, we want to be eye level with the child and stay face to face with them so that they can read our lips if they need to. We want to make sure that we establish eye contact before we start talking to them to make sure that they're actually focused on us and can hear the message that we're sending. And then making sure that we talk in short sentences. They're going to need some extra time to process and then the opportunity to ask you to repeat something if they need to. We want to avoid using exaggerated face or lip movements so that we're not distorting the message. So if they're reading your lips and you're trying to extra enunciate things, it might not look the same as if you were speaking regularly. So here is our first critical thinking discussion. We have a nurse assigned to a 2-year-old who's been scheduled for a myringotomy with tube insertion, so where we make that incision in the tympanic membrane. How should the nurse explain the surgical intervention and its indications? And then what instructions do we need to provide at discharge?
She's going to explain that they're going to make an incision into the tympanic membrane.
Yeah. And we're going to put tubes in so that we can get that ventilation and drainage. Why do we do this? Why do we go this extreme?
To relieve pressure.
Permanently deaf, right?
So you're going to see this in kids that have those repeated ear infections or those chronic ones that last 3 months or longer. So that's when we're going to jump to the surgical intervention.
Don't the tubes come out on their own or when it's supposed to fall?
Yep.
Okay, I just want.
Yep. So 6 to 12 months after placement, they can fall out on their own. Yep. What do we need to tell parents post-operatively or going home?
Cold compress for swelling.
Yep. What do we want to teach them how to do?
Keep what ideas?
Yeah. Yep. But what about their medications?
Administer the eardrops.
Yeah, how to give the eardrops. Also making sure that they take them for the full prescribed time. What happens if the tubes fall out right after surgery?
Don't they have to get replaced?
Yep, call a doctor so we can get them back in. Perfect, guys. So our eyes are something that progresses, so our vision also progresses. So our newborns don't have mature sight. They can only see 8 to 12 inches from their face, and they can only focus for a few seconds at a time. So everything for them is just kind of blurry. They see general shapes of things, but definition is definitely not something that they can distinguish yet. They don't develop their depth perception until they're about 9 months old. So again, they can't tell things are near or far to them. They should be able to fixate on an object by about 6 weeks of age. So that's when we can start assessing their visual abilities. When we're choosing an object to have them focus on, we want to make sure that it doesn't make sound so that they're focused on the sound rather than whether or not they can actually see something. And we'll start routine visual acuity test at 2 to 3 years of age. When we're looking at visual impairments, we have a bunch of different conditions that we see, and it'll be important for you to know the differences between them. So myopia is going to be nearsightedness, and it is the most common refractive error of the eye. So that is a disruption in how the eye processes light. Hyperopia is going to be farsightedness. They can see better far away than they can up close. Then we have strabismus, which is crossed eyes. And that's where they can't direct both eyes toward the same object. So in order to overcome that, the brain will disable one eye to give them a clear image. So they'll really only be using one eye at a time. Then we have amblyopia, which is lazy eye. And then nystagmus are the jerking movements in the eye. So if you sit and look at somebody and you see their eye just sit there and wiggle, that's nystagmus. So it can be horizontal, vertical, or it can be in a circular motion. So when we're treating strabismus and amblyopia, we can use an eye patch. So we're going to patch their unaffected eye, so their good eye, so that their bad eye is forced to get stronger. So by covering the good one, we force the brain to work with the bad one so that we can increase its strength and correct the disorder. You can also use glasses and eye exercises to help strengthen that eye. And then if that doesn't work, then we can do surgery. We also have infections of the eye, so conjunctivitis, and that's going to be an inflammation of the mucous membranes that line the eye. And we're going to give eye drops, antibiotics, and if that doesn't work, then we can do systemic antibiotics. We want to make sure that we're not using steroids in patients that have conjunctivitis because it can make the infection worse. Then making sure that we're doing good hand hygiene so that we're not spreading it. It's one of those things that's really easy to spread from person to person. Retinoblastomas are going to be malignant tumors of the retina. They have a yellowish white reflex in their pupil because the tumor sits behind the lens. So we call that either a cat eyes reflex or leukocoria. You can see this in conjunction with vision loss, strabismus, hyphema, and if the tumor is advanced, then they might have pain associated with it. We treat this with laser photocoagulation, chemotherapy, radiation, and then if none of those work, as a last resort, we can remove the eye to save the vision, and that's called enucleation. So our nervous system is our body's communication center. It's going to transmit messages all throughout the body, record experiences, and then it's going to integrate those stimuli that we're receiving. Most of our neurologic disabilities in childhood are going to come from congenital malformations, brain injury, or infections. When we're trying to remember our cranial nerves, there's a couple different ways that we can use. There's a mnemonic. Only one of the two athletes felt very good, victorious, and healthy, and that will help you to put your cranial nerves in order. Or for people that don't do well with mnemonics, that are more visual learners, you can put your cranial nerves around a clock, and that will tell you the order again of your cranial nerves. So just two ways to help you study your cranial nerves, whichever works better for you.
Excuse me. Will the cranial nerves be on the exam?
Yes, there are some cranial nerves. Yep.
Can I look at the last slide?
Yep.
Okay, thank you.
Yep. Okay, talking about altered level of consciousness. So that's going to be a change in the awareness of environmental stimuli, the ability to react to stimuli, and the cognitive ability to respond to verbal or physical stimuli in an age-appropriate manner. So you're not functioning like you normally would. There's lots of causes of it. If our oxygen drops or our carbon dioxide goes sky high, low blood pressure causing us not to be able to perfuse our brain appropriately, a fever. So for every 1 degree rise we have in temperature, it increases our oxygen need by 10%. So if you have a really high fever for an extended period of time, you're going to be using up way more oxygen than your body can take in. So you're going to have that hypoxia again. We also have medications that can cause a change in our consciousness, whether it be purposeful or not. We also have the post-ictal state of seizures, where they tend to be drowsy and confused. And then increased intracranial pressure can also cause changes. If you ever have a sudden appearance of fixed and dilated pupils, that is going to be a neurologic emergency. Typically, our cranial nerves can be affected at this point. The other thing that we need to be on the lookout for is Reye's syndrome. So this is a non-inflammatory encephalopathy and hepatology that follows a viral infection in children. It typically occurs when we use aspirin or medications that contain salicylates in kids with flu-like symptoms. So we want to make sure that our parents are reading their medication labels carefully and not giving aspirin when their kids have flu-like symptoms. Meningitis is going to be inflammation in the meninges of the brain and spinal cord, and it's typically caused by group B strep. You get a lot of flu-like symptoms. They also have a stiff neck. They're sensitive to light. You can have that altered level of consciousness, rapid breathing. They can also be agitated. In our infant population, you can have bulging fontanelles, and they can also have poor feeding or be irritable. Two signs that we look for with meningitis are Brudzinski sign, which is where if you flex the neck forward, their knees and their hips will automatically flex. The other one is Kernig's sign, and that is if you flex a child's hip 90 degrees, they can't straighten their leg. Which one did you experience, Key?
He late with the meningitis.
Yeah. Did he have Brudzinski's sign or Kernig's?
Curtis.
Okay. Yep. So both of these are just indications of an irritated spinal cord. So things aren't firing correctly, which is why we're having these abnormal postures and movements. We diagnose meningitis by looking at our cerebral spinal fluid through our lumbar puncture. We make sure that they are in droplet precautions until we make sure we have the right antibiotics on board for the first 24 hours. We're going to be doing routine neurologic checks, reporting any weakness of the limbs, speech difficulties, confusion, behavior issues, and then making sure that we're keeping a close eye on our vitals and I's and O's. It's really important that we keep a quiet environment for them and decrease stimuli as much as possible. Their brain's going to just be overly sensitive to everything with all the irritation going on. So that swelling and irritation from the infection is just going to cause them to react to an extreme with everything. So we really need to promote that ability for the brain to just rest. Seizures. We have lots of different types of seizures. And it's important that you can tell the difference between which type of seizure it is. So be able to identify your different seizures. So our febrile seizures are most common in our 6-month to 5-year-old children. And they're a response to a fever that's over 102. That's going to require treatment. So we've got to bring that fever down as soon as we can so that we can stop these seizures from happening. Then we have epilepsy, can be classified as general or partial. Our generalized seizures are going to be our tonic-clonic, so those typical seizures, or our grand mal seizures. They have 3 distinct phases to them. They have an aura, the tonic-clonic seizure, and then a post-ictal phase where they're kind of dazed and confused. Our partial seizures account for about 40%. They can still retain their consciousness during a partial seizure, and they can be simple or complex. So a lot of times you'll hear these referred to as absent seizures, where all of a sudden they'll just stare off into space, and then they only last a couple seconds and they'll come back. When we're teaching our parents, we want to tell them about all the potential triggers. So flashing lights like strobe lights, startling movements, overhydration, and photosensitivity. So being aware of those potential triggers. And then factors that can cause seizures, you will see this again, are infection, fever, epilepsy, drugs, and hypoglycemia. So those are all things that could cause seizures. When we're diagnosing seizures, we need to know the type, the site, and the cause. We can use lots of different diagnostics. We can do a CT or MRI. We can do an EEG to look at the actual brain waves. And then we do lab tests to make sure that we're ruling out things like poisoning or those electrolyte abnormalities that can cause seizures. The medication that we use to treat the seizure is going to depend on the type. We need to watch for those common side effects like drowsiness and making sure that our patients are taking their medication at the same time every day. That's really important for them. And then making sure that they don't stop it suddenly, because that can cause them to go into status epilepticus, which is going to be a prolonged seizure. We can also do diet changes for patients that aren't responding well to their anticonvulsants. So we'll recommend a ketogenic diet, and that's going to be high in fats and low in carbohydrates. And it produces ketoacidosis, which will reduce those convulsive episodes. We talked about this in one of our discussion questions with seizure precautions. We want to make sure that we keep our side rails up and that they're padded. The child should have a medical ID bracelet on. We need to provide supervision when they're doing potentially hazardous activities like swimming, avoiding our triggers, and then making sure that parents are compliant with the medication regimen. So here we have a 3-year-old boy with a new diagnosis of a seizure disorder. What possible types of seizures might he be experiencing? And what should the nurse observe and document about his seizure activity? And then what do we tell parents for discharge instructions? So what type of seizures could he be experiencing?
Epilepsy.
Febrile.
Febrile seizures.
Epilepsy.
Yep.
Partial seizures.
Yep. Partial seizures, generalized seizures.
Absent.
Yep. Good job, guys. What do we need to document about a patient having seizures?
How long? So the time.
Yep. How long?
What they were doing when they had the seizure, when the seizure occurred.
Yeah. What they were doing. Did they have any warning signs?
Abnormal movements.
Yep. We need to know, what did it look like? What do we need to instruct parents for action to take if the child has a seizure?
Don't hold them down and
Lay them on their side.
make sure nothing's in their mouth.
Yep. Don't put anything in
Call
the
Lay them on
911.
their side.
Yep. Lay them on their side. Have them laying down so they're not going to fall over.
Clear their area, their surrounding area.
Yep. Make sure they're not going to run into anything.
Loose and tight clothing.
Yep. You guys got it.
And time it.
Yep. Absolutely. Make sure that they time it. Obviously, if the child stops breathing, parents should call 911. Or if they're not responding to their medications. Our next topic is going to be cerebral palsy. So that's going to be a group of motor disorders caused by dysfunction of various motor centers. And it's typically caused by antenatal or developmental factors. So things like birth injuries, congenital anomalies, neonatal anoxia. So if their brain is deprived of oxygen for an extended period of time. Prematurity, where you've got that really immature brain that's going to be more prone to hemorrhages. So subdural hemorrhages. And then prenatal infections are also all risk factors. So it's going to vary with each child, ranging from mild to severe, and your intellectual and developmental disabilities are going to depend on what motor centers are affected. We can suspect this as early as infancy. We'll start noticing things like feeding problems. We'll have convulsions that aren't accompanied with a fever. And then we'll be missing those developmental milestones. Sometimes we can mistake this for a type of seizure because you have that altered level of consciousness, but it won't ever respond to anti-epileptic medication. We can use Botox as a form of treatment, and that is going to work by blocking the chemical signals between your nerves and your muscles that make the muscle contract or tighten. So it's going to decrease that spasticity by keeping the muscle relaxed. Each treatment plan is going to be highly individualized, but overall, they're going to need really good skincare. We're going to also need to take action to prevent contractures. So we'll use things like braces, and sometimes we'll need to do orthopedic surgery. When we're figuring out a treatment protocol, we're going to work very closely with the family. We're going to need to figure out a reliable communication method. So a lot of these children will be nonverbal, or they might not be able to speak, and then also have some motor deficits that we need to account for. So figuring out how we're going to communicate. We also need to optimize their motor functions. So figure out how we're going to get them to be able to move, increasing that range of motion so that we're not getting those contractures. They also need intellectual and social stimulation. They're just like every other child. So we can use technology to encourage those self-care behaviors and promote that growth and development and help with that socialization. We have things like text to speech, eye tracking devices, and voice synthesizers that we can use. And then making sure that we are providing that multidisciplinary approach to care, getting all of our therapies involved, social work, so that we have resources and support systems, making sure that we're taking advantage of everybody that we can bring to the table. Even though a child is intellectually impaired, they still have the same psychosocial needs as any other child. The only difference is they can't express or respond to them in the same way that we would expect. They need opportunities for success. So we need to encourage parents to focus on the child's strengths and give them those opportunities to be successful at something. If they're constantly experiencing failure, they can become angry and it can result in behavioral difficulties. Like we talked about, we need an individualized plan of care. So making sure that we are really focused on what's important to the family, giving them that emotional support, making sure that we're having the best outcomes for the child. In the hospital, it's important that we know the child's stages of maturation, their abilities, what they can do on their own versus what they need help with, and then what their home routines are so that we can try and incorporate those as much as possible. We want to make sure that we're emphasizing the strengths that they have, keeping that open communication, not using labels, and then making sure that we keep the school involved. Do they need a school nurse? Do they need a one-on-one attendant? Making sure that we have a plan in place for them to be able to have that school experience. And then providing those referrals for support groups, anything out in the community that might help them. So here we have a 6-year-old boy with cerebral palsy from a near drowning experience 16 months ago. His parents would like to know what they should expect of the child regarding his education and future, and why would a near drowning cause cerebral palsy? What should the nurse tell the parents about realistic goals for their son? So let's start with why a near drowning might cause cerebral palsy. Anybody know?
Maybe because they couldn't breathe, it was causing breathing damage.
To the brain.
Yep, no oxygen to their brain. We've got that prolonged time where they don't have oxygen to the brain. What about the child's education and future? Realistic goals for him. Where do we start?
Maybe educate them on the dangers of deep water.
Yep, we could start with education, but at this point we're already stuck with what we've got. So how do we focus on a plan moving forward?
I mean, being is that there's damage done to the part of the brain, you can try to get it back. I don't know if that makes any sense.
Yeah, start with what they've got, what they can do, and figure out what it is that they might be able to do by building on those skills. Yep. Is it important for him to go to school and have a normal experience there, or as normal as we can make it?
I
Yeah.
think so.
Yeah, we still need that educational experience. We still need socialization. So it's really all about optimizing this child's life. So creating as much normal as we can. Who all do we need to talk to and get involved in this plan?
Everybody, the
Everybody?
staff, the school,
Yep.
Case
PT,
manager.
OT, yeah.
Yeah, lots of people involved. So parents, schools, therapies, social work, so that we're getting those resources, case managers, making sure they have all the supplies and everything they need. Yep. These are really hard conversations to have, but they're really important so that we can make sure that we are really supporting this family. When we're looking at head injuries, we have lots of different head injuries, starting with concussions. So we have different signs and symptoms that we can see, but the things that we need to be aware of are hypoxia, increased intracranial pressure, cerebral edema, and infection that can happen within a couple days of a head injury. So hypoxia causes the brain to need increased energy, which is going to increase our cerebral blood flow. So that increased blood flow is going to create that edema. And then if we have an increased intracranial pressure that rises too high, we're actually going to cut off the perfusion to the brain that can end up killing off parts of our brain. You'll also see things like increased blood pressure and then decreased pulses and respirations. So a concussion is where we have that violent jarring or shaking of the head that is going to end up with a disturbance in our brain function. So a concussion that's symptomatic. So we have a concussion and we have amnesia or confusion afterwards is going to be more serious than if we had actually fractured our skull and didn't have any clinical symptoms. So even though we can't actually see the injury, because it's a symptomatic injury, it's going to be worse than if we could actually see a fracture. We also need to be on the lookout for shaken baby syndrome. So this is an infant that's going to be roughly shaken, and they can have retinal, subarachnoid, and subdural hemorrhages in their brain, as well as high-level cervical spine injuries. It can result in permanent brain injury or death. Some of the symptoms we see are headaches. So in our toddlers, they're just going to be kind of fussy. See drowsiness, blurred vision, vomiting, difficulty breathing, and then in severe cases, they may be unconscious. We need to be on the lookout for posturing, so that abnormal positioning. So the way to tell it apart, we have decorticate posturing, which is our flexed posturing, is where our arms are going to be moving inwards towards the core, and they're going to be shaped like C's. So those are going to be problems with our cervical spinal tract or our cerebral hemisphere. Decerebrate posturing, which is our extensor posturing, our arms are going to be turned out like E's. Those are going to be problems within our midbrain or pons. So that's how you tell them apart, whether they're C's or E's. When we're observing for signs of increased intracranial pressure, we want to do that neurological check where we're looking for our level of consciousness, our pupils and eye movement, our vitals, and our motor activity. Our neurologic monitoring is going to include all of those things, plus assessing our cranial nerves, their motor responses, looking for that posturing, assessing their fontanelles. So bulging fontanelles are going to be an indication of increased intracranial pressure. Scalp vein distension is going to tell us that we have increased blood flow to our brain. Ataxia is spasticity of our lower extremities. And then that moro or tonic neck with withdrawal reflexes. So those are all things that we're looking for. accidental or near drowning is going to be the fourth leading cause of death in children under 19. And near drowning is going to be defined as that survival beyond 24 hours after being submerged. Our priorities for treatment are going to be reversing that hypoxia, assessing for aspiration, and then reversing that hypothermia. So we need to warm them slowly so that we're not causing an overwhelming cascade to the body. And then CNS injury is going to be the major cause of death or long-term disability in these kids. If we're submerged for more than 10 minutes and we don't regain consciousness at the scene or within the first 24 hours, that's going to be a very ominous sign. It's going to indicate severe neurological deficits if the child is able to survive at all. So here we have a 7-month-old baby girl brought into the ER by her mother's boyfriend who was babysitting. The baby is irritable. The nurse overhears the physician say that he suspects shaken baby syndrome. What might cause him to have that suspicion? And what signs should the nurses look for that indicate he suffered a head injury?
The bulging fontanelle.
A bulging fontanelle, yeah.
Vomiting.
Vomiting.
Decreased consciousness.
Yeah, you might see irritability or you could see them being completely lethargic, either one.
Trouble breathing,
Yep, trouble breathing.
headache.
Yep. What else might we see on the child? If somebody picked them up and shook them really hard, what might we see on them?
Wouldn't it be like could they have the, what's it called? Where they get like splotches? What's it called? Dang it.
Stinky eyes?
Yeah.
You might, not necessarily. What might you see in their eyes though?
The pupils are
Broken blood vessels.
non-reactive.
Yep, you can see pupil changes, but you can also see retinal hemorrhages. So those blood vessels can burst and you'll see bleeding in their eyes. Yep. So obviously we can't see into their brain, but if they have retinal hemorrhages, they might also have bleeding somewhere in their brain. Something else that we can see is we can actually see bruises from the handprint of the parent or whoever shook the child, either on their upper arms, if they had their arms tucked in when they were grabbed, or you can see them along their rib cage. You can also see broken ribs from this. What things do we need to monitor for that would tell us that the child's condition is worsening?
Loss of consciousness.
Yep,
Convulsions,
yep,
vomiting,
yep.
swelling of the head.
You guys got it. Increased fussiness, any posturing, difficulty breathing, those pupil changes, those are all going to indicate that we have a change in our condition. Okay. Questions about neurologic disorders? Okay, we'll move on to our musculoskeletal conditions. So our muscles and our skeletal system work together to support our body and allow us to move. Our ability to be able to move is going to develop gradually and in a very orderly manner. We know there's lots of differences in the child skeletal system and the adults. So we know they have that rapid period of growth in infancy and also in adolescence. Their bones are a lot more resilient than adults. They tend to bend before they break. They have a rich blood supply, so they heal a lot faster. They have those growth plates that if we fracture, we can disrupt the ability of the bone to grow. And we know that sometimes musculoskeletal problems are caused by those rapid periods of growth. When we're assessing our musculoskeletal system, we need to look at the gait and muscle tone, need to palpate our muscles, look at range of motion, and do those neurovascular checks to check for sensation and blood flow. Any child who can't walk independently by 18 months could indicate that they have a serious delay that needs followed up on. When we're looking at gait, we know our toddlers like to waddle. They have that really wide gait and they walk kind of side to side. Their arms don't swing when they're walking. By 18 months, they start to narrow their base and they're going to be a lot more stable when they're walking. By 4 years old, they can do things like hop on one foot, and we start to see that arm swing when they're walking. And then by the time they're 6, they should have pretty much a normal adult gait. So their arms should swing, they should be nice and steady. When we're examining our muscle tone, we want to look for symmetry and the overall contour. We want to check our reflexes, do a sensory assessment, and watch for things like spasms. We have lots of diagnostic tests that we can do to help us determine any abnormalities. We can do bone scans, CTs, MRIs, and ultrasounds. We also do lab tests like CBCs and erythrocyte sedimentation rates, or ESRs, and those help us rule out septic arthritis or osteomyelitis. And then human leukocyte antigen B27 is going to help us diagnose rheumatologic disorders. We have lots of treatments that we can do. We can do arthroscopy when we need to see inside of a joint. We can do a bone biopsy where we take a small sample of the bone and look at it under a microscope. We use traction a lot, and that helps us to be able to straighten broken bones and relieve pressure on the spine or the skeletal system. And then we're probably all pretty familiar with casting and splints for those orthopedic injuries. So when we're treating injuries, those soft tissue injuries, we're going to use the acronym RICE. So rest, ice, compression, and elevation. And that's going to limit our damage from edema and bleeding. So those soft tissue injuries are going to be contusions, sprains, and strains. Our contusions are going to be tearing of our subcutaneous tissue that result in hemorrhage, edema, and pain. So those hematomas or giant bruises, those black and blue marks. A sprain is going to be when ligament is torn or stretched away from the bone, resulting in damage to our blood vessels, muscles, and nerves. So here you're going to see swelling, disability, and pain. And then strains are going to be our less serious microscopic tears to a muscle or tendon over time that result in edema and pain. So those are going to be those long-term overuse injuries. Need to make sure that we're treating it immediately so we limit the damage, making sure that we're preventing as many of these injuries as we can using our safety equipment, and making sure that we're stretching when we're exercising, and then making sure that we're using proper pedestrian safety. As simple as that is, making sure that we're not running out and causing ourselves to twist an ankle or something. Looking at pediatric trauma, there's a lot of injury prevention that we could do. So making sure that we're using our car seats appropriately, using our protective gear like helmets, having pull fences, window bars, door locks, locks on our cabinets as well. This is just a visual of the types of fractures that we're going to cover. you will be responsible for being able to differentiate between the types of fractures. We're going to go over those here next. So the first one we have is a green stick fracture. So I like to think of this like a tree limb, those really young tree limbs where they snap on one side, but not all the way through. They just kind of bend once they've started to break. So this is going to be an incomplete fracture where one side of the bone is broken, but the other one is just bent. So it's not a complete break. You have a compound fracture where you have a wound in addition to your broken bone. So there you're going to have the added danger of infection with that open wound. A simple fracture is where your bone is going to be broken, but the skin is still going to be intact. An oblique fracture is going to be a diagonal fracture on your x-ray. So it's going to be a complete break at an angle across the bone. So you're going to see that nice diagonal line across your x-ray. And then a spiral fracture. So that's going to be forceful twisting motion of the bone. And is going to be an indication of child abuse. So that's somebody literally took the bone and twisted it in opposite directions. And it makes this spiralized fracture. Some of the things that we need to watch out for with child abuse risk factors are going to be poverty, unemployment, substance abuse, low educational level, a history of abuse as a child. So if you were abused, you're more likely to continue that pattern. Substance abuse, and the presence of financial or emotional crisis. Traumatic fractures are fractures in the bone caused by an accident. You might have some discoloration, limited movement, some numbness, also pain and tenderness and swelling. They're going to still heal more rapidly because we've got that increased blood flow. If it would happen at a growth plate, then you can have that interference with the longitudinal growth. Talking about traction care. So there's two mnemonics that we use in relation to traction. So the first one is traction itself. So we look at the temperature of both the extremity and the patient's overall temperature. So if we take their temperature and they have a fever, it could indicate infection. If we are looking at the extremity, we're making sure that we have adequate blood perfusion. We want to make sure our ropes are hanging freely, that our limb is in alignment. We're going to do our circulation checks. We also need to look at the type and location of the fracture. We're going to increase our fluid intake, decide whether or not we need to use an overhead trapeze for positioning, and then making sure our weights aren't on the bed or the floor. So the other one that we use is fracture. So we want to make sure that they're on a firm mattress, that we're preventing foot drop. We also want to do range of motion for those unaffected extremities so that we're not getting stiff from laying in bed. Making sure that we're in alignment, watching for those complications. Like we said before, using a trapeze, watching for urinary retention, respiratory complications, and then evaluating our circulation. So those are your two mnemonics for traction care. So we will ask you the differences between the types of traction. So Bryant's traction is going to be our younger children, typically for a fractured femur. In Bryant's traction, their buttocks is going to be slightly off of the bed so that we're providing counter traction. For our really active kiddos, they might need a jacket restraint so that they're not twisting their upper body and messing up their alignment. So that's just going to help to keep them in the position that we want them in. For buckskin traction, it's going to be used in an older child, and we're going to use it when the cast can't keep the bones in alignment. So it's going to pull the hip and the leg into extension And again, it's going to be used for those fractured femurs. The counter traction is going to be supplied by the patient's body. So we need to make sure that they don't slide down in bed. Need to make sure our bed's not in high Fowlers because that's going to make them slide. And then we can also use this to reduce our pain and muscle spasms that are associated with their hip coming out of socket. So we'll talk about that slipped capital femoral epiphysis in a couple slides. But it's most important to know that we need to be doing those routine neurovascular checks. So anytime we have a fracture and we notice a pale or cyanotic limb below our fracture site, it indicates poor circulation and restricted blood flow. And that needs to be reported right away. Our Russell's traction is going to be similar to our Bucks, but this is going to have a sling underneath the knee and it's going to suspend the thigh above the bed. So this is going to pull in 2 directions instead of just one. And it prevents those bones from sliding underneath each other. So here we use 2 sets of weights, one at the head and one at the foot. For skeletal traction, it's important that we are preventing infection. So we need to be doing good skin assessments, making sure our patients are hydrated, making sure they're doing their deep breathing so that we're preventing pneumonia and aspiration, and then giving them the PID care. So when we do skeletal traction, we have increased risk of infection from any bacteria on the skin being able to creep in through those pin sites and make it into the bone. That's why we harp on meticulous skin and pin care so that we can prevent that osteomyelitis. So some signs of infection or osteomyelitis are going to be fever, redness, swelling, and increased pain. A nice little checklist for our patients in traction. We want to make sure that their body's in alignment. Their head of bed isn't higher than 20 degrees. Need to keep their heels off of the bed so that we're not getting those pressure ulcers from not being able to move around. Doing that range of motion so that we're keeping our blood flowing. Still going to use those anti-embolism stockings or foot pumps for that circulation. And then doing our neurovascular checks, as well as assessing our skin. And then staying on top of pain medication, making sure that they're not getting constipated from all of the pain meds that we're giving. And then using a trapeze for changing position so that you make sure that you have good support and alignment. When we're looking at our equipment, we need to make sure that our weights are hanging freely and that they're out of the reach of the child. Need to make sure that our ropes stay in our pulleys and that the knots aren't up against the pulley so that they're not able to move around. Want to make sure that our bed linens aren't getting tangled in our traction ropes and that they have appropriate counter traction. And then making sure that we're not having our apparatus up against the foot of the bed. So those neurovascular checks tell us that we have appropriate tissue perfusion past the site of the injury. Any abnormals need to be reported immediately. So we're going to look at our pulse rate and quality, the color, our cap refill, warmth, and movement and sensation. And the easy way to remember that is looking for our 5 Ps. So pain, pulse, pallor, paresthesias, which are those sensations, and then paralysis. So your 5 Ps are going to be your neurovascular assessment. So here we have a fun scenario. We're out jogging on a trail. Suddenly, a 10-year-old boy swerves his bicycle around you, loses control of the bike, and falls 8 feet in front of you. Initially, he denies sustaining any injury, but the nurse notices that he's limping when he goes to retrieve his bicycle. How do we handle this situation?
Assess him.
Yeah, absolutely. We need to do an assessment. What are important things to know about him?
His age,
Medical history.
Medical history. Yeah.
if they're nearby.
Yeah. We need to know a good history on this patient. It might be a limp that happened beforehand and not related to the accident at all. So those are important things to know. What should we observe for in this boy?
Swelling or redness.
Yep. Looking for those signs of either a soft tissue injury or if it might be worse to a break of some variety. What do we want to make sure we have him do since he sustained an injury?
All his parents.
Yeah, call his parents. Good job. You guys are all on top of that. What are we gonna have his parents do if it were just a soft tissue injury?
Ice on it, ice it, elevate it.
Yeah. That's gonna be those RICE interventions. So rest, ice, compression, elevation. Good job. And then notify the physician if you start noticing anything getting worse. Good job, guys. Let's talk about cast and splints. So we know we can make them from a variety of materials. Any child in a cast or splint is going to be at increased risk of impaired skin integrity because it's stuck under that cast where we can't get to it. And then also compartment syndrome, and that's going to be a progressive loss of perfusion because of an increase in pressure caused by that swelling. So that's going to press on the vessels and the tissues. If we don't carefully monitor that, you can have significant complications. You can even lose your extremity from compartment syndrome. So the material that we make our cast out of is going to determine how we position our extremity for the first 72 hours. And that's while we're waiting for that cast to dry and set and be fully formed. If we use a fiberglass cast, the client can bathe and go in water. But if they have a plaster cast, then they can't get it wet at all. No matter what, we're going to keep that extremity elevated on a pillow so that we're decreasing our risk of swelling. We're going to do those neurovascular checks and then teach parents how to care for it, how to transfer and use crutches if they need them, and then how to assess if it's too loose or too tight. Osteomyelitis is that bone infection. Some of our common organisms are going to be Staph aureus and Haemophilus influenza. You might see a local injury before. So you could have an open fracture that then leads to osteomyelitis because they had a skin infection that progressed down into the bone. We can diagnose it on X-ray. Bone scans are going to be more reliable than our x-rays. We can also see an elevated white blood cell and erythrocyte sedimentation rate. They're going to be on long-term antibiotics, antimicrobials. If there's pus, we need to make sure that we're draining it and that the bone is going to be immobilized so that we're not spreading that nastiness around. Once we're in a splint, we can do some passive range of motion. Need to make sure that we're doing pain relief and physical therapy. Duchenne's or Becker's muscular dystrophy is going to be a group of disorders with progressive muscle degeneration. It only occurs in males. typically between 2 and 6 years of age, and they're going to present with a history of delayed motor development. You're going to get that progressive muscle weakness and atrophy. However, their calf muscle is going to be hypertrophied. You're going to see them walk on their tippy toes. They're never going to drop their heel and walk flat-footed. Have trouble climbing upstairs. They're going to fall a lot, be fatigued. As the disease progresses, you can get into things like breathing problems. Also see scoliosis, short stature in these patients. That progressive weakness is going to cause them to frequently fall, be considered clumsy. You can also notice contractures of the hips and ankles. And then they do Gower's maneuver to rise from the floor. So it's kind of like your elderly patients where they have to do this progression to be able to get up from the floor. So they've got to slowly work themselves up, kind of using their body to be able to get to completely standing. And then this is often accompanied with intellectual impairments and obesity. Becker's is going to have a slower progression than Duchenne's. And then the cause of death is usually going to be from those complications like cardiac failure or respiratory infections. Our job is to support them and prevent the complications as much as we can while maintaining that quality of life. So the slipped femoral capital epiphysis is where the head of the femur slips out of the hip socket. It occurs most often during rapid growth, so our pre-adolescence, not related to any trauma. You're going to see thigh pain. You might have a limp and an inability to bear weight on that leg. So we use Buck's traction to minimize that slippage of the hip until we can surgically correct it. Legg-Calvé-Perthes disease is going to be similar, but this is where we're going to have a disorder in the blood flow to the end of the bone is going to be disrupted. So we're not going to be getting blood to the end of the bone, and that's going to result in tissue death and possibly affect the development of the head of the femur. So you're going to see this in boys 5 to 12. And it will heal spontaneously over 2 to 4 years. So it's going to take a long time to recover. And you might have that long-term distortion of the head of the femur. So you can see the difference between having that nice rounded femur head into the socket versus this real flat one. We talked about having the painless limp. You might have limited motion. We can use x-rays and bone scans. And they might require a hip replacement at some point. Osteosarcomas are going to be malignant tumors of the long bones, typically occurring in 10 to 15-year-olds. Are kids that have had radiation for other types of cancer, and kids with retinoblastomas are going to be at higher risk for having an osteosarcoma. And they metastasize very quickly because they're in the bone, and that bone is going to be very vascular. So our lungs are going to be our primary site of our metastasis. You're going to see pain and swelling at the site. They might be lessened if they flex the extremity. And you can also see pathologic fractures. We're going to confirm this by biopsy. We can also do some radiology studies. Typically, treatment is going to end up being a radical resection or amputation of the limb. They can still have phantom limb pain even after we remove that limb because the nerves are going to continue to report that pain. So if we amputate their left leg below the knee, they might still say that their left foot hurts. Ewing sarcoma is going to be a malignant growth in the marrow of the long bones. It's going to be in our older school-age children and early adolescents. If we see metastasis with Ewing sarcoma, it's going to have a poor prognosis. And again, we're going to see those metastases in the lungs, but also the long bones. And these kids are going to have radiation and chemotherapy. Juvenile idiopathic arthritis is the same thing as juvenile rheumatoid arthritis, and it's going to be our most common arthritic condition in childhood. We see it most in our 1 to 3 year olds, and it is a systemic autoimmune disease. So we see it involving our joints, connective tissue, and the viscera. We want to make sure that we know if symptoms are lasting longer than 6 weeks. We don't have any specific tests or cures. We can just treat the symptoms. So things we see are morning stiffness, difficulty walking, limping, joint swelling, and uveitis. So that reddening of the eyeball there. We have 3 distinct methods of onset that we'll talk about a little bit more. We have systemic polyarticular, which is where we have lots of joints involved, or polyarticular, where we have fewer joints involved. So oligoarthritis is going to be limited to 4 or fewer joints. Typically, we see it in our big joints like our hips, knees, and ankles, elbows. It's going to be in our girls that are under 3. We can see that pain in the eye, the inflammation. They might have redness, be sensitive to light, not be able to see as well, and have non-reactive pupils. Then we have polyarthritis, where we have 5 or more joints included. We typically see this in our hands and feet. So they'll be warm, swollen, and tender. And this happens throughout childhood and adolescence. Again, predominantly in girls. Then systemic is going to be in our children that are 1 to 3 and 8 to 10. And they're going to have these intermittent fevers above 103 that last over 10 days. They also have a rash associated with it, abdominal pain, and they're going to have that elevated ESR and C-reactive protein. So your erythrocyte sedimentation rate, and then your CRP, which is going to be an indication of inflammation. Our goals for therapy are going to be to reduce the pain and swelling, promote mobility and growth and development, allow for independent functioning, and helping the family to cope with the chronic illness. We can give medications like NSAIDs and methotrexate to help to reduce the joint pain and swelling. And then we can help promote function of the joint by resting, using splints, moist heat and exercise, therapeutic play, and swimming. It is going to be a long-term disease that has periods of remission and exacerbations. We need to help the family to advocate for the child's needs. So making sure that those are being met. Torticollis is going to be limited motion of the neck because of the sternocleidoid mastoid muscle being shortened. Can be congenital, which is most common, where they're just born with it, or acquired. It can be associated with breech and forceps deliveries, also in conjunction with birth defects like congenital hip dysplasia. So typically we'll see symptoms present at birth. They're going to hold their head to one side. Sometimes you can feel a hard palpable mass over top of the muscle tissue. It should resolve by 2 to 6 months of age. And we use passive stretching and range of motion physical therapy to help stretch out that muscle again. If it's seen in older children, it's typically acquired and it can be associated with an injury, inflammation, neurologic disorders, improper positioning. So if the child's constantly laying a certain way, you can develop torticollis. Scoliosis is going to be that S-shaped curve of the spine. It's more common in girls, and we have two different types. So we have functional, that's caused by poor posture, and structural, which is going to be from changes in the shape of your vertebrae or the thorax. So we see that rotation of the spine, the hips and shoulders can be uneven. And then if they bend forward with their arms together, one arm will be longer than the other. So that's that test that we all did in grade school in gym class, where they had you stick your arms together and then lean forward. And you see that one arm slide forward. Our treatment is going to be aimed at correcting that curvature and making sure that we're not developing severe scoliosis. So our curves that are 20 degrees or less, we can just do physical therapy and exercise to correct those. Curves that are 20 to 40 degrees are going to require a brace. So that typically that Milwaukee brace that they wear over top of a t-shirt for 23 hours a day. Pretty much just take it off long enough to shower and that's it. Anything over 40 degrees is going to require surgery. So that's where they do a spinal fusion. We have lots of different sports activities related to strenuous activity involved, especially in our middle school and high school students. We have concussions, stingers, and then strained or sprained muscles, hips, shin splints, all the above. And then we have our sports that are more at risk for injuries, and those are things with lots of risk for falling and twisting, like gymnastics or wrestling. We have our contact sports like football and hockey, basketball, skiing or snowboarding. Again, you're at high risk for falling. So lots of opportunities for injury. We also need to talk about family violence. So it affects children of all social classes, can include spousal and child abuse, neglect, and maltreatment. There's lots of different triggers. There's stresses involving the social life, the child themselves, the parental stresses, and then lots of triggers like discipline, family conflict, substance abuse, financial crises. It's important that we know the difference between abuse and neglect. So emotional abuse is just verbal acts of destroying the self-esteem. Emotional neglect is where you're intentionally refusing to communicate or interact with the child. Sexual abuse is going to be performing acts on the child for sexual gratification of the adult. Physical neglect is going to be failure to provide for those basic needs, where physical abuse is going to be deliberately inflicting injury. So the difference is between abuse and neglect. As healthcare workers, we are mandated reporters. So we need to report any suspected abuse or neglect, and any report that we make in good faith will protect us from anything coming back on us. We can also report anonymously to child services if we don't feel comfortable revealing our identity. Once a report's been made, Child Protective Services will gather all the facts that they can, then let the parents know that there's been a report filed. They'll go out and visit the home within 48 to 72 hours, and then make their judgments based on their home visit and all the information that they've gathered. It's important that you know your state laws regarding mandated reporting. So sometimes the states are a little bit different. When we're looking for child abuse signs and symptoms, we can see those retinal hemorrhages like we saw in shaken baby syndrome. You might see a child that's dressed inappropriately for the weather. So it could be summertime and they're in long sleeves, long pants, socks, trying to cover up as much as we can. Can also see failure to thrive, any bruises, scars, wounds that don't seem like they should be there, looking for imprints on the child's skin, such as the shape of a hand or an object. Making sure that we're looking for things like dirty clothes or skin rashes that could indicate neglect. Making sure that we are believing the child when they tell us they've been abused. And then looking at their story and the parent's story and the injuries and seeing if they all match. And it's important that we don't criticize the parent or the caregiver in front of the child, because they're still going to have that relationship with their parent that we need to maintain. We also need to know the differences in the healing stages of bruises. That's going to help us to determine potential signs of abuse. So the first couple days, they're just swollen and tender, but then as they're healing 2 weeks down the line, they're going to be brown. So if we see all these different stages at the same time, it indicates multiple sources of injury. So that's going to be a sign of child abuse. Whereas if we had bruises that all look the same, it could be that we just, fell down and rolled down a hill or something, and we have multiple injuries that way. But those different stages that are all present at the same time are going to indicate a repeated pattern. We also need to be sure that when we're assessing for abuse, that we're taking into consideration alternative therapies. So if you remember one of the very first talks that we had, we talked about alternative medicine practices and cupping specifically. So in cupping, you get those perfect circular things that look like bruises, but it's not a bruise. It's just that form of treatment. So making sure that we have all the facts before we jump to the conclusions. Making sure that we're documenting all the signs that we see, as well as any interactions between the parent and child that raise any red flags. And then allowing Child Protective Services to take control and take the lead once we've reported our concerns. Hey guys, last question. Mom gets a call from her 12-year-old daughter's school nurse. The nurse informs her that her daughter has scoliosis, which was detected during a routine school testing. The mother's never heard of scoliosis and is concerned that her daughter will be crippled for life. What should the school nurse tell her?
Provide her patient information and to follow up with the pediatrician.
Yep.
Let her know it's a common condition in adolescent girls.
Yeah, it's very common in adolescent girls. Do we think she's going to be crippled from it?
No, she can't be
No.
treated.
No, not likely. What are some of the things that we do to treat scoliosis?
Physical therapy.
Uh-huh.
The back brace.
Yep.
Maybe the surgery. If it
Medication
needs to be.
versus it.
Yeah. So, I mean, it could be as simple as needing physical therapy, might have to wear a back brace for a while. Worst case scenario, we're looking at surgery to correct it, but it'll still be a condition that we can correct.
Can you get medication to suppress it?
No,
No.
that's going to be that curvature of the spine. So we can't give
Okay.
anything to correct that.
Okay.
It would be, doing that therapy or that brace to help bring it back into alignment. You might need medications for like pain management and swelling. But outside of that, we don't have like a medical treatment that we could do. She shouldn't have any pain with it. She might have some pain when she's doing therapy and the brace. But outside of that, it should not interfere with her everyday life. Okay. That is it for our slides tonight. I will get our Kahoot set up here. Okay, I will be right back, guys, while you guys are getting logged in. Maybe another minute or so to get logged in here. I stuck the code in the chat for anybody that has to join us late. Otherwise, you guys can just follow along on the screen. Let's get started. The brain extraction is reserved for our kids that are less than 30 pounds. What intervention will the nurse caring for a child in buckskin traction implement? And that's making sure that they're pulled up in bed. So our skin fractures are going to be moderate to severe pain. So it would be appropriate to use an opioid for those. So if it were just mild pain, then ibuprofen would be appropriate. But typically with a fractured femur, you're gonna have a moderate to severe amount of pain. So anytime we have a child in traction, we want to make sure that their skin isn't getting irritated from the equipment that we're using. So that's going to be part of our assessment is checking their skin. So this goes back to last week's discussion, and pain is whatever the patient says it is. When we're giving oral antibiotics for otitis media, it's important that we give the medication for the entire length of treatment. So making sure that we're giving all the doses until all the medication is used. When we're communicating with the hearing impaired child, we want to make sure that we're face to face at eye level with them, that we have that eye contact so that we know they're paying attention to us, and that we talk in short sentences, giving them opportunity to process and ask us to repeat if they need us to. So again, the best way to communicate with a hearing impaired child is going to be to make sure that we're facing them and we're speaking clearly in short sentences. You guys can check your cameras. We got a lot of cameras that have shifted or aren't on right now. Characteristics of Ewing sarcoma, which statement indicates understanding, and that disease is going to be sensitive to radiation and chemotherapy, which is why that's our course of treatment for them. The Duchenne's muscular dystrophy is that progressive muscular disease. So you're going to see children that fall frequently or are classified as clumsy. So we're looking for the incorrect statement about treating a sprained ankle. And that's going to be warm compresses. We use ice to treat a sprain. So rest, ice, compression, elevation. How is pain managed the most effective way? And that's going to be giving those low dose analgesics around the clock. So making sure that we're keeping our medication scheduled and not waiting until the last minute to hit it with a heavy hitting medication. So that proactive pain management. Russell's traction supplies continuous pull in two directions. So remember, that's where the leg is going to be elevated off the bed. And so we're going to have pull in both directions for that. What finding with the nurse assessing the neurovascular status of a child in Russell's traction report immediately? That's gonna be that bluish coloration of the skin. So we've got decreased perfusion if our extremity is blue. When we're assessing for scoliosis, we do that screening test by having the child bend forward at the waist and looking for that asymmetry. So have them stick their arms together and lean forward. Arne, are you still with us? There you are. What nursing action will significantly decrease the risk of serious complications for a child in Bryant's traction? And that's going to be those neurovascular checks. So making sure that we have good perfusion and circulation. With juvenile rheumatoid arthritis, they tend to be really stiff in the morning or after sitting in one position for a prolonged period. So applying moist heat packs when they wake up might help to loosen up those muscles, those joints. So instructions for a Milwaukee brace. Wear it over a t-shirt for 23 hours a day. So that t-shirt's going to prevent any friction or rubbing, some skin scores and breakdown. And then it has to be on for 23 hours a day so that we get that correction of the spine. What's going to be a red flag for child abuse when a mom comes in saying that their child fell? So that's going to be those multiple stages of bruise healing. So those red, green, yellow bruises on their body. what's going to require nursing intervention for a patient in traction, and that's when you find their heels firmly placed against the foot of the bed. So that bucks traction, they're not going to be able to straighten out that fracture if they're pushed all the way against the bed. So signs of physical abuse are going to be those spiral fractures. Remember, that's one that is from a twisting of the bone, very difficult to occur in a natural setting. Those triggers for abuse are going to be those stressors or that history. So, substance abuse, overwhelming responsibility, being abused as a child, and financial issues. Those strabismus is your crossed eyes, where both eyes can't focus on the same thing. So you might see a child in school cover one eye so that they can focus on the chalkboard. So the same thing that we would do with patching, they're trying to get, in their case, they're trying to get their good eye to focus. But when we would patch their eye, we would make their bad eye do the work so that it gets better. Remember, strabismus and amblyopia are treated the same way. So we're going to patch the good eye to force the brain to use the affected eye. The cardinal sign of hyphema is going to be a dark red spot in the front of the iris. So that's going to be an indication of bleeding. An incomplete fracture where only one side of the bone is broken is going to be a green stick fracture. For a child with febrile seizures, those happen when you have a sudden rise in the patient's temperature. So watching for those sudden increases in temp will cause febrile seizures. This is that same question. Spiral fractures are going to be associated with child abuse. So those triggers of child abuse are going to be all of these things, those stressful situations. So financial difficulties, a pattern of abuse, drug abuse, and unemployment. So absence or partial seizures are where a patient just all of a sudden starts staring off into space. So they won't be responsive at all. They'll just have a fixed gaze, typically off to the side. So for tonic-clonic seizures, we want to make sure that we get everything out of the child's immediate area so that they can't injure themselves on anything. We never want to put anything in their mouth or manually restrain them. We can cause more injuries that way. So spastic CP is where they have those involuntary jerky movements that you can see. A drop in blood pressure in a patient with meningitis should be reported. That's gonna be a sign of sepsis, so a worsening of the infection. So a sign of a concussion after falling is gonna be that amnesia afterwards, so not remembering what happened. Last question. Or Haemophilus influenza type B or Hib vaccine protects us against influenza. So let's see who our winner was today. Congratulations to Z for being our winner today.